Bismillah ar-Rahman ar-Rahim. Alhamdulillah Rabbil Alamin. Sallallahu Alaihi Wasallam. Barak ala Nabiyyina Muhammad. Welcome back to our sessions with the pathophysiology of congenital heart disease. We have done the cyanotic congenital heart disease, acyanotic congenital heart disease, obstructive right-sided congenital heart disease. Today we'll be talking about pathophysiology of left-sided obstructive congenital heart disease lesions. And inshallah, in the next couple of sessions, we'll talk also about regurgitant lesions and possibly about some of the acquired heart diseases pathophysiology. So what are the left-sided structures that can be obstructed in the human heart? We can start from within the lung, which is the pulmonary veins, up to their connection with the left atrium. So these are the two right veins, these are the two left veins, upper veins, lower veins, 1, 2, 3, 4. Anywhere in the course of the vein, a stenosis can happen, whether it's at the junction with the left atrium or just before or deep in the lung. The severity of such disease is different, but obviously when we have involvement of the intraparenchymal pulmonary veins with the stenosis, including all its length up to the entrance to the left atrium, then this is a very severe form of pulmonary vein stenosis. This is just to show you or to tell you where the obstruction can be. It can be just within the lung, somewhere between the entrance and the lung, or at the entrance. Anyhow, it will cause hindrance or prevention of the pulmonary venous blood flow from going into the left atrium. Before we go into the deep pathophysiology of such disease, we can say that it does not mean when we have pulmonary vein stenosis that all the veins should be involved. It could be one vein, two veins, one side, other side is okay, or all of them are actually stenotic. Whenever we have a single pulmonary vein involved, usually that does not produce significant pathophysiology. That means the physiology, the normal physiology of return of the pulmonary venous blood flow from the lung will just continue in its usual way and will not have a pathophysiological effect. So let's take one vein. Let's say this is the left lower vein, which is actually commonly involved and being a single vein stenosis. If this vein has a stenosis, then the left lower lobe of the lung, the left lower lobe of the lung, this is the left pulmonary artery, this is the upper lobe, and this is the lower lobe artery. This lobe here, which is actually the larger lobe, and this is the upper lobe. This lobe here, its vein, when it's coming back, if it becomes stenotic, okay, and let's say it's just hypoplastic, it's stenotic throughout its course. You see, it's almost obliterated. This lower lobe will be congested. The venous pulmonary blood flow will not be able to empty into the left atrium. So the left lower lobe will be congested, full of interstitial fluid because of capillary or venular intravascular fluid leaking into the extravascular compartment, causing interstitial edema or pulmonary venous edema in that lobe. Nothing much will happen in terms of pulmonary pressure, in terms of right ventricular pressure, in terms of amount of blood going enough to the left atrium, to the left ventricle, and giving enough cardiac output. It is just part of the lung, so it usually will not cause a major issue. In the lung itself, it does, because we might end up having that this lobe becomes dysfunctional in terms of what? In terms of oxygenation of blood and in terms of ventilation and removal of CO2. And usually what happens first is, because of the pulmonary edema, we lose the ability to get rid of the CO2, and we can end up that this lobe actually becomes completely dysfunctional. Being a left lower lobe, it's an important lobe. It compromises about 2/3 of the left lung. So we might have symptoms, some respiratory distress, some physical ability decrease, not that complete free of symptoms in the patient, but the pathophysiology will be very limited to only this lobe, causing changes in this lobe. Obviously, this is not great. It depends if these changes are severe enough. Something has to be done to relieve this obstruction. If it is only a mild or a moderate, then the rule applies that one vein stenosis will not need therapy because it does not cause significant pathophysiology. In the very rare occasion, if this is severe enough and it is involving the left lower lobe or a right lower lobe, which is also a big lobe, it very rarely may cause reflex pulmonary arteriolar vasoconstriction in the other lung, and probably in the upper lobe, the normal lobe of the left lung, and then it will cause some degree of pulmonary hypertension, usually mild. I don't think it will ever exceed moderate, but then we do have a pathophysiological effect, although, as I said, this is quite rare. And most of the time, the left lower lobe will find venous channel collaterals that can join the right upper pulmonary vein and enter into the left atrium. So decompressing the left lower lobe, and that's why we usually do not have, when we only have one vein stenosis, we do not have much of pathophysiological effect. From this, I'll move to, what if we have two veins? It depends if these two veins are actually on the same side or on one on each side. Obviously, if we have two pulmonary vein stenosis on the same side, let's say it's the right or the left, then that whole lung will be obstructed. The pulmonary venous return from that lung will be obstructed. At this stage, just to finish up with the simple part, let's say it's one vein on the left and one vein on the right. Again, because it is one here and one there, probably not much pathophysiological effect will happen other than what I have just described, the congestion of the lobe that the vein drains, and in the rare occasion, a mild to maybe moderate pulmonary hypertension, not leading to much more than that, and usually collateralizing with other veins to be able to empty. That finishes the issue of one vein, whether it's unilateral or bilateral. Now let's talk about the real stuff, which, let's say we have unilateral, right-sided, all vein stenosis. The two veins are stenotic. So the right lung, this is the right pulmonary artery. with an upper lobe branch, a middle lobe branch, and a lower lobe branch. Sorry for the drawing. Just take it away. Because I drew them not so proportional to their sizes. Usually the upper lobe is smaller, the middle lobe slightly larger, and the lower lobe is the largest part. So if this lung, the right lung, is obstructed, its venous return, which are these two veins, if let's say this is now the left atrium, the veins are coming from within, they form into the vein, and the other vein. If these veins are stenotic, these right-sided, without the SVC obviously, if these right-sided pulmonary veins are stenotic, whether at lumen or at orifice or total length, if these veins are stenotic, then we have to talk about, are they mildly stenotic? Are they moderately stenotic? Are they severely stenotic? When we say, are they mildly stenotic, we mean that there is probably a pressure difference the left atrium. If we say that they are only mildly stenotic, then the pressure difference between the left atrial pressure and the venous pressure, the intraparenchymal venous pressure, is probably less than or equal 5 millimeter mercury. Mild pulmonary vein stenosis, pressure gradient less than or equal 5 millimeter mercury. In such a stage, we know that the left atrial pressure, normal left atrial pressure, is anything between 4 to 8 millimeter mercury. So let's assume a 5 and assume the highest number. Then the pressure here will be 13 millimeter mercury. What's a normal pressure in the pulmonary artery? We've said before that the systolic pressure of a normal artery can be up to 25 millimeter, or less than actually 25 millimeter mercury. Still, the pressure here, the back pressure, is much lower than the pulmonary artery pressure. Usually the diastolic will be 10, and then the mean will be around, the mean pressure here will be around 15 to 18 millimeter mercury. This 15 to 18 millimeter mercury is higher than this 13 millimeter mercury, so obviously the flow can continue with probably mild or no elevation in the mean pulmonary artery pressure. And in such condition, that would be probably the only pathophysiological effect. A mild rise in the mean pulmonary artery pressure. Blood can still go in mild pulmonary stenosis even if it's full unilateral, that means the two veins, and the lungs will be mildly congested. No symptoms should be expected, except maybe on severe exercise. We do not expect true pulmonary venous edema in this lung. So, and that would apply obviously even to the left side if it is unilateral. What if we have bilateral mild pulmonary vein stenosis? Again, we probably would not expect much pathophysiological effect other than mild dilatation and enlargement of the pulmonary veins, whether intraparenchymal or outside the lung, mild or very little extravasation of pulmonary venous fluid into the extra vascular compartment, and maybe mild pulmonary edema, and again a mild, not more than mild, elevation of the pulmonary artery pressure, which the RV, the right ventricle, can handle very well. I mean, we said that this is the pulmonary artery. Where is it connecting? This is the left. It's connecting obviously through the pulmonary vein, to the pulmonary valve, sorry, to exactly the right ventricle. Then this pulmonary artery, which is supposed to be here, like that, will reflect that mild elevation of pressure because of the mild stenosis, whether unilateral or bilateral, on the right ventricle. This will not cause anything to the right ventricle. Not much hypertrophy, not much dilatation, function should not be affected, cardiac output should be maintained, no venous congestion on the right side because of such stenosis. You can notice in what I have said that though this is a left-sided obstruction, but its effect truly, because it's before entering the heart, it's before entering actually specifically the left ventricle, its effect is almost on the lungs and the right side. This is mild pulmonary vein stenosis, gradient less than or equal 5 millimeter mercury, whether unilateral or bilateral. The effect is mild elevation of the pulmonary veins within the lung, intraparenchymal, and a possible mild elevation of the mean pulmonary arteriolar pressure because of this mild venous congestion and elevation of the pressure in the lung. From this, I will move on to talk about moderate pulmonary venous obstruction, and then it's a totally different story. Although mild to moderate or moderate pulmonary vein obstruction, stenosis, does not require interference from us, I mean surgically or interventionally, because still the cardiac output can be maintained, still the right ventricle pressure and function and cardiac and output will not be significantly affected, still the lungs will not be severely congested with extravascular pulmonary interstitial venous edema, and so on. It will be just a pathophysiological effect. And what do we call moderate pulmonary vein stenosis? How do we grade it? If the mean gradient, the pressure difference between the area after the obstruction and the area above the obstruction, that means the veins within the lung, and where the stenosis ends, let's say it ends at the left atrial entrance or orifice, then it's the difference between the left atrium and the area above, measured by Doppler or measured in the cath lab by direct pressure measurement. We talk about a mean of above 5 millimeter mercury, but less than 10 millimeter mercury. Or let's say, just to make it easy, less than 12 millimeter mercury. So a 5 to 12 in that range will be considered moderate. And here we are talking no more about single vein stenosis. We're talking either about a unilateral, 2 veins, or all the veins are involved in the stenosis in a moderate fashion. It means if I put my Doppler by echocardiography, or if I put my catheter and measure, I will find that the pressure difference between the low area, which is the receiving part, which is the left atrium, and the area above the obstruction is more than 5 millimeter mercury, but less than 12 millimeter mercury. Let's apply the same that we talked about before. If, let's say, just for simplicity, this is now, we talked about the right lung, let's talk now about the left lung. This is the left pulmonary artery, left upper branch, left lower, the left lung, and these are the left veins coming out. Okay, just for simplicity of drawing. It is not absolutely accurate, but I'm going to try to make it a touch more accurate. Something like that. Okay, so if these veins are involved in a moderate fashion, let's say the obstruction is where it enters the left atrium, then if we know that the normal pressure within these veins is now elevated above the normal by at least 5 to 12, we said before that the left atrial mean pressure is normal between 4 to 8 millimeter mercury. Let's take now the 8 plus the maximum, which is 12, less than 12, let's say 11. So 19 millimeter mercury will be the pressure within the intraparenchymal pulmonary vein. It will be here 19 millimeter mercury. If you remember, we just said before that the normal mean here is anything between probably 13 up to 18 maximum millimeter mercury. This is the mean PA arteriolar or artery pressure. If now this is 19 and this is supposed to be normally 13 to 18, no blood can pass. The pressure is just not enough to push the blood. Obviously, this pressure will never remain now 13. Let's add the normal here would be around what? Let's say 8, so we have 11 difference. We will add that 11 difference to the lower mean, 13. Now, because of this moderate pulmonary venous stenosis, our mean pulmonary arteriolar pressure will be at least 24, 11 plus 13, and it can be up to 30 millimeter mercury. You can see here now we are reaching pulmonary hypertension by definition. For sure that this pulmonary artery now is hypertensive. Fortunate enough, even if it was 30 mean pulmonary artery pressure, the right ventricular pressure, let's say it has an end diastolic pressure of normal 6, let's say just 8, just for pushing it to the maximum, then the RV pressure here will be around 38 or 40 millimeter mercury. This pressure is still low enough for the right ventricle to be able to function near normal with not much hypertrophy, maybe slight hypertrophy, but not much hypertrophy, not much dilatation, no decrease in cardiac output, no backward venous congestion in the right atrium and in SVC and the IVC, no significant tricuspid valve regurg or pulmonary valve regurg because of the high pressure, because it's still a moderately elevated mean pressure. It is not a severely elevated mean pressure. Let me take back, this is the mean. Probably the systolic here will be around 50. I'm sorry, it's not 38. It'll be around 50. Again, a pressure that the right ventricle can take quite well, although it's reaching the limit where the right ventricle may start showing some changes. Obviously, if it's moderate and left for a very long time, the effect might be seen more on the right ventricle, showing some hypertrophy and maybe some tricuspid regurg, but the cardiac output will be maintained. The venous congestion on the systemic veins will not happen, but definitely we will have pulmonary venous congestion in the whole lung that's there, and it will give symptoms of dyspnea on exertion, probably on moderate exertion, and it should not give any hypoxemia, it should not give any hypercapnia, no change in acid-base balance, because again, the cardiac output through the lung and to the heart and from the heart to the body will be maintained. And that's why even in moderate pulmonary vein stenosis, we probably do not need to intervene surgically or interventionally. We may need to use some medications to relieve the pulmonary venous edema. Not much medications really to relieve the stenosis, but probably diuretics, just relieving the preload, because now the preload in the lung is increased because of the obstruction, because the lung is not being able to empty properly in the left atrium, and hence we will have pulmonary venous edema. Any other pathophysiology that can be expected with such pulmonary vein stenosis, moderate? What happens to the cardiac output and the left atrium and the left ventricle? In most of the cases, nothing will happen. The left atrium size will be almost normal. The left ventricle size will be almost normal. The cardiac output to the left side should be normal, because yes, there is a stenosis, but the pulmonary artery will elevate its pressure and will be able to push the blood to the pulmonary arteries through the veins and get to the left side. With exercise, with severe exercise, moderate to severe exercise, with extra demand, this may give more symptoms or become more significant. So I hope I've explained this part. And finally, we will go for the pulmonary veins to severe pulmonary venous stenosis. And here, and when we say severe pulmonary vein stenosis, whether it is unilateral or bilateral, it will affect the right ventricle, and it will affect the the pulmonary pressure, and can affect the patient quite significantly. So severe pulmonary vein Stenosis, mean or pressure gradient between the left atrium and the proximal part of the vein will be more than or equal to 12 millimeter mercury. Usually talking about 15 to 18 millimeter mercury. So this is quite a severe obstruction. Again, why? Let's take it from numbers point of view. The left atrial pressure, we said the mean is 4 to 8. Let's say, just for simplicity, it is 8 mean pressure in the left atrium. If we take a middle number, that the gradient across the obstructed veins is 15 millimeter mercury. So 8 plus 15, that's 23. Let's go back to our lung. If this is now the right lung, right pulmonary artery, upper lobe, middle lobe, and lower lobe. Okay, if, I guess my hand drawing is deteriorating sometimes, so sorry for that. Let me just put it back in a better drawing. That's better. This is the right pulmonary artery. So if this pressure is mean of 8 and we have now a stenosis mean of 15, 8 plus 15 is 23, so this is the right lung. So the intraparenchymal venous pressure now is 23 millimeter mercury. Okay, let's just make it. It is now 23 millimeter mercury in the venous side. We said that the mean pulmonary artery pressure is anything between 12 to 18 millimeter mercury as normal. If we now take 18 plus 23, that's already a mean of 41. So now we will have severe elevation of the pulmonary artery pressure. If the mean here becomes 41 millimeter mercury, if this is the mean, and we assume a difference between the mean of around 20 to 30, if we just take a 20, then the systolic PA pressure in such situation will equal 20 plus 41, that's 61 millimeter mercury. That will give us, if we add the 8 diastolic and diastolic pressure of the right ventricle, then the right ventricle pressure now, just for simplicity, add 9. 61 plus 9, now it is 70. This is severe elevation of right ventricular pressure. Right pulmonary artery pressure now is severely affected, severely elevated. Right ventricular pressure now is severely elevated because it is severe pulmonary vein stenosis. Here, we expect the back effect of such stenosis on the lungs, causing severe, significant pulmonary venous edema. Even if it was unilateral, the other side will have reflex pulmonary venous congestion and will add to the pulmonary hypertension. But if it was unilateral, The only difference will be, although the pressure will be equal in the two lungs, equally elevated, very high, the only difference, if it is unilateral, the lung that has its veins obstructed will be congested and will have pulmonary venous obstruction. If it was bilateral, then both lungs will look hazy and with a ground glass appearance of pulmonary interstitial edema on both sides. So now we have significant pulmonary venous pressure elevation leading to extravasation of the intravascular fluid to the vascular compartment, causing significant pulmonary edema, number one, and with all its pathophysiological findings and complications, by the way, we can end up, we will end up, by the grace of Allah, that the PA pressure will be elevated and the right ventricular pressure will be elevated severely. Pulmonary artery pressure, severe elevation, can have pathophysiological effect on the lung itself. Usually with obstructive left-sided lesions, these pathophysiological effects on the pulmonary arteriolar bed are quite delayed, and most of the time they are actually reversible. It's not like primary pulmonary hypertension, where the acceleration of vascular injury and vasculopathy and the diminution of the pulmonary vascular bed, arterial vascular bed, is more. In obstructive lesion, though it causes, like in severe pulmonary stenosis, severe elevation of the pulmonary artery pressure, these arteriolar changes from intimal injury to thrombosis to fibrosis to complete obliteration, irreversible, all these stages are quite delayed, but if left for a long time, they can happen. And relieving the stenosis after that long time may still leave the patient with significant pulmonary hypertension with all its pathophysiological and clinical effect. So this is the part we talked about the veins, the pressure and its effect in the pulmonary artery side. What about the elevation of the pressure in the main pulmonary artery? Obviously, there will be pulmonary valve regurgitation as a pathophysiological effect. Usually, this regurgitation does not add much to the pathophysiological importance of such disease because it's usually mild, maximally moderate, and that would not add any volume load, any significant volume load to the right ventricle. The problem here will be major pressure load on the right ventricle, not because of obstruction of the right side, but obstruction of the left side, leading to reflex pulmonary hypertension and right ventricular hypertension, with all its effect of significant right ventricular hypertrophy. So let's write it. It will have significant right ventricular hypertrophy. May cause, if untreated for a long time, may cause significant decrease in RV systolic function. And if we just continue up, it will give us tricuspid valve regurgitation, and that can vary from mild to moderate to severe depending on the RV function and the severity of the severe pulmonary hypertension, and depending on how much right ventricular dilatation and failure happens because of the severe elevation of the pulmonary artery pressure because of the severe pulmonary stenosis. So tricuspid regurg can be mild, moderate, severe. Mild to moderate may not cause much addition to the pathophysiological effect of severe pulmonary stenosis, but obviously moderate to severe and severe will cause deleterious effect on the right ventricle, causing more dilatation of the right atrium and enlargement, congestion of the pulmonary venous return with all the effect that we have spoken about before in severe obstruction of the right side. Here is almost similar. It's not an obstruction, it's just an elevation of the pressure. So at this stage, we should expect all right ventricular hypertrophy, we talked about, right ventricular systolic function being affected, right ventricular diastolic function also being affected, because the right ventricular and diastolic pressure will also elevate significantly because of the elevation of the systolic pressure and the significant right ventricular hypertrophy, possible dilatation and possible decreased systolic function, plus maybe added to by the significance of the tricuspid valve regurgitation. So we just move up. We know in such situation the cardiac output may not be maintained quite well, and it can be actually a significant emergency if this is happening very early in life and more on a fast or an acute way. If it's more chronic, then it's more tolerable. If it is not, no, then it becomes like a real emergency, and the patient may have significant bilateral pulmonary edema plus minus the right-sided ventricular failure with all its complications. So cardiac output can be limited in this situation. Right side cardiac output and left side cardiac output. Not much blood will be coming into the left atrium because of this severe stenosis, unless there is an ASD somewhere where this right-sided congested blood can escape into the left side and maintain the cardiac output on the expense of the patient becoming significantly cyanotic. These patients with severe pulmonary stenosis, they will not look cyanotic because most of them do not have the ASD. They will actually look dusky, grayish color, typical presentation of somebody with low cardiac output state, and obviously they have severe or significant respiratory distress, hypoxemia, hypercapnia because of the significant pulmonary edema. Another pathophysiological effect can happen is that their left atrium may be much smaller because it hasn't received much volume. Their left ventricle may be also smaller because it did not receive significant cardiac output or flow to grow and take its normal size. Other left-sided obstructive lesions like aortic stenosis, coarctation of the aorta may also happen with these lesions, not necessarily because of the flow theory, the decreased flow theory, but in part it is because of this theory. So in such patient with severe pulmonary vein stenosis, we have major pathophysiological effect. I will end up the last pathophysiological effect which can happen because of the right ventricular significant dilatation and dysfunction, the right atrial significant dilatation and dysfunction. Arrhythmias can be expected, mostly atrial, but it can be ventricular arrhythmia, can be significant. One more pathophysiological effect if it is left because of the severe elevation of the pulmonary artery pressure and the venous obstruction, pulmonary hemorrhage can happen. So, and this is really the end stage part of the pathophysiology. I hope I've explained pulmonary venous stenosis in a good way, in an easy way to understand, but we always have to think with obstruction, What is the gradients? What is the pressure difference? How much does that affect in a change or in an increase the normal pressure? And how much is that compared to mild to moderate to severe? And when it's severe, what are the effects? The effects are usually, are they on the lung? Are they on the atria? Are they on the ventricle? Are they on the cardiac output? Are they on the venous return, systemic? Are they on the pulmonary vein, systemic? If we always think in this kind of a comprehensive way, whatever lesion I may give you, you will actually be able to figure out the pathophysiology if you follow a very logical thinking in such patients. Thank you.